Can you hear me?
Yes, it's working.
Okay. So, as we know, guys, we had, I said like we'll have like 4 main sessions of mechanical ventilation. And today will be the last session for the basics of mechanical ventilation. And it should be from this session we can start, like, as we mentioned before, having like some mechanical ventilation from from the ICU or from St. Mary or Cabell, like you have a picture of any one of like having synchrony, then we will do it as a chest complex. We can have like once a month having like 2 or 3 mechanical ventilation waveform with the synchrony, and then we can go over it, and with time you will find yourself like improving. So as usual, we'll start with a quick review for the previous session. So the most important thing that you need to memorize is equation, which is the equation of motion. So as we mentioned before, so the mechanical ventilation, we can control, we can take over the mechanical ventilation and put the numbers and control volume, pressure, stuff like that. But the patient is the other component. So if the patient not paralyzed, not in deep sedation, we have 2 things that we need to control, right? We have the patient muscles and we have a pressure coming from mechanical ventilation. So if you look at here, we have 2 powers that can adjust the mechanical, the lung mechanics. So the power of the patient muscles and the powers of the patient mechanical ventilation itself. So these 2 powers, it could be elasticity and volume, which is the volume control, and the other part of this equation, which is the resistance and the flow. So as we are like when you are the physician in the ICU and you are trying to control the mechanical ventilation, so you can control the mechanical ventilation with the right side of this equation, which is the volume control. I'm the one who can put the patient in volume control, or I put the patient in pressure control. However, if I'm the one who's controlling the volume, then the pressure is not controlled. It'll be like it's controlled by the patient mechanics itself. If I'm the one controlling the pressure, then as we mentioned, the patient will control the volume part. So, and as we know, resistance and flow goes together. So we have to have, like, if I have very narrow airways that will have like high resistance, and we need like higher power and pressure to overcome this resistance and flow. All right, so this is the most important. If my patient's in paralytics, then the PMUS will be out. It will be only PVent. I'm the one who's controlling everything. Is that right? But not controlling volume and pressure at the same time, controlling one, and the machine and the patient lung mechanics will take care of the rest. Because even if you are paralyzed with an ARDS, you still have a bad disease, all right? You still have a very low compliance. It doesn't mean that you are paralyzed means I paralyzed your diaphragm, but I did not fix the main problem, which is the compliance or the high elasticity, okay? All right, so a quick review that will not take more than a few minutes. So we divided our lecture to pressure, flow, and volume. We talked about the pressure, we talked about the flow, we talked about the taxonomy, or like the naming or the tag of the mechanical ventilation. So pressure waveform, we said when the pressure starting from from the PEEP, which is that's the 0 for the patient. The pressure starts from the PEEP and goes straight to the peak, and that's what we call, that's the peak pressure or the P peak. And then if I stop and make it like no more flow going on, it's a steady, that's what we call the plateau pressure. And that what rest like we don't start, like there is no negative usually in our mechanical ventilation. Always we start with a PEEP. You can do a PEEP 0, PEEP 5, PEEP of 10. It depends on your patient PEEP. And the difference between the peak pressure and the plateau pressure, that's what we determine our resistance. And we have to add the flow to that equation. We'll talk about it. And the difference between the plateau pressure and peak pressure, that's what will determine our compliance, and as well as what we call that is the driving pressure. All right. So in this, like it changes in here, we can see like the baseline is going down a little bit, and that's what we said. We know the patient is trying to trigger the vent, and that's the patient initiating the breath. So, however, if the patient initiating the breath, it doesn't mean that breath is not assisted by the mechanical ventilation. Just the patient started the breath, but the rest of the vent or the rest of the breath was controlled by the mechanical ventilation. And the first time in here, we said the inspiratory flow time, the inspiratory pause, and the whole thing is the inspiratory time. So we said airway resistance, which is the peak pressure minus the plateau pressure divided by flow, and normally should be less than 10. And the static compliance, we said it is like the volume divided by the driving pressure, which is the plateau minus the peak. The dynamic compliance, it's the peak minus the plateau. However, we care more about the static compliance, and we care about the resistance for a follow-up for your patient. Then we talked about the flow. When we talked about the flow, we said if we are volume controlled, then the flow is fixed, and that's what we control. And if it's pressure controlled, the flow is variable. The patient can play with the flow. So the thing is, in a volume control, usually we have two different ways of volume of flow, which is in volume control can be square or it could be decelerating. So those are the two ways that we can see in volume control. However, in some new machines that you can see the sinusoidal, or you can see even accelerating flow. We don't use it. The common thing that we use is like the square and the decelerating waveform. The one that is close to the normal, like patient, like me and you right now, we are talking and doing everything. It's the decelerating flow, not the constant flow. So then, why do we do constant flow? The constant square flow mainly in patients with like. You have an ARDS patient and you would like to control everything, and you had a good measurement for your stress index, for your compliance, for your plateau and everything. It's better to be taken in a constant square flow. And in COPD patient, if you do decelerating, that will take longer time inspiration sometimes. That's why like sometimes in the COPD patient, we can do a constant square that will give you shorter time for the inspiration and more time for the expiration. However, you can control in both of them. You can control the timing during inspiration. So that's about the flow. All right. And then we talked about like, why should we like even know this? Why should we like know the variables and everything? The machine is safe volume control. The machine is safe pressure control. And all of you guys who work with me, I showed you that the machine safe volume control. However, the machine actually it's a pressure control. And sometimes it saves pressure control, and the machine does both of them, do the pressure and the volume at the same time. So that's why knowing this, because nowadays we have a lot of companies, is that right? And they have like a lot of different names, but as a physician, you need to know what is the machine doing. Because you can be like two types of physician. You can be that physician stand beside the bedside and saying, oh, just like that, he's over breathing or he's over breathing the vent, paralyzed. Or you can be that type of physician standing in there. What type of mechanical ventilation is this? Let me see what's going on. What's wrong with this mechanical ventilation? Let's fix this and fix this. Why there's these two types of physician? The first one, he will prolong the days of mechanical ventilation. The first one, he will prolong the days being in the hospital. The first one, he will make the patient able to have like more risk for having pneumonia and while he's in the hospital and complications from the mechanical ventilation. The second one, he will try to do his best to get out of this. However, sometimes even I stop and do everything I cannot get out of it, then I need to paralyze the patient, but I have done everything that I can do. So we said I'm talking fast just because it's a quick review, guys, okay? But you are with me, is that right? So the control variables, we said we control pressure or we control volume, is that right? That's the control variable. If I'm controlling volume, Ramsha, if I'm controlling volume, so is the flow constant or can be changed? It's okay. Feel free.
Constant. We can put the flow as constant, but it will be constant.
It will be constant. I cannot touch it. The patient cannot do anything with the flow, is that right, during inspiration? Because we say it's volume control, actually it's flow control, okay? But pressure control, if I put a patient in pressure control, Mahmoud, so if a patient is in pressure control, so what the machine can play with? So I'm the one who will put the pressure control.
The flow.
Yes, the flow and the volume. It depends on what? That's right. Good. So that's the pressure. We have only two ways of control, pressure or volume. That's it. And then we have the breath sequence. What does that mean? We said that like in the last lecture, the breath sequence is the patient taking control. He's initiating the breath and ending the breath. Okay? Is the machine is the one who's initiating or ending or both. So the machine is, there's a control for the machine, or it's intermittent. Some of the breath the patient will control, some of the breath will be controlled by the machine. Is that right? That's why we have three main categories. We have the continuous spontaneous ventilation, which that's the machine, the patient trigger and the breath. We have the mandatory one, which is the CMV. That's the patient trigger, the machine will end, or the machine trigger and the patient will end. Okay, or the machine is triggered and end. So there's a control for the machine. So when I look at the patient duration of inspiration, it has to be exactly the same. Why is that? Because the machine is controlling this. However, if I'm taking it, if the machine giving like, let's say 14 breaths per minute, so, and the patient breathing 20, and the patient is continuous mandatory ventilation, okay, CMV. So the machine is 14 and the patient is 20. So the breath that the patient will take by himself, it will be supported by the machine, all right? It doesn't matter. It will be supported with the machine. If the patient takes only 10 breaths and the machine is 14, the patient has to deliver the 14 breaths, and it's all covered by the machine. But in intermittent mandatory ventilation, so if there's multiple types, but just a quick review. If the patient, like let's say that I'm patient mechanical ventilation and he's breathing by himself spontaneously, and I put the machine on 14 breaths per minute. So the patient will have his spontaneous breathing, which it will look like PSV because the patient is initiating and the patient is ending, is that right? And every time I will look like some of the breaths will come as mandatory. Weird. There's like spontaneous and mandatory in the same screen, is that right? This is like intermittent ventilation. There's another side. The machine will not give you any breath, if you do spontaneous. Let's say that I put the machine on 14 breaths per minute, but the patient's breathing 16 and by himself. So there's no support for those breaths, like the patient does by himself. After like few hours, patient has an event, something happened, went down to 10. So 10 will be by the patient, and the rest, the 4, will be by the machine. There's some of them will leave the patient do it by himself, and I will put the minute ventilation. I need this patient to have a minute, not me, which is the company or the machine itself. This patient minute ventilation should be like, let's say, 12 liters, okay? And then the patient is doing 12 liters, he got tired, and his muscle got weak, and then he starts to have less minute ventilation. That's when the mandatory will jump in and start. That's all intermittent mandatory ventilation. So BRVC, that's a different scenario, but it's intermittent. BRVC is a continuous mandatory volume, but it's with adaptive, and that's a different topic. All right, and then we said the targeting scheme, which is the sit point. Am I the one who's controlling when the patient should stop breathing, like I put these in the machine, or I'm leaving that for the machine itself to decide? It's mandatory. It's like CMV, and it's like, but I'm not the one who's saying like I need the volume. This like as the BRVC. BRVC is the pressure control. Is that right? So we think it's volume because we put the volume in, but it's a pressure control. But I let the machine take over. The machine will like decide, oh, okay, let's see how the patient breathing. I'll give him like first 3 breaths. Okay, now I know how the patient mechanics or lung mechanics. I will give him this pressure and this time of inspiration to deliver this volume. But you are leaving the machine to do it. So the machine is adapt itself to do that. Okay, so we have sit point, dual, and adaptive. All right, and those are the types. It could be like it can be volume control with a continuous mandatory volume ventilation. Sorry, it could be volume control with intermittent mandatory volume. It could be pressure control with continuous mandatory ventilator, or pressure control with intermittent, or pressure control with the continuous spontaneous ventilation, which is like when we put our patients on pressure support. Okay. All right. Kareem, what's this? Volume control or pressure control?
So flow is constant to volume control.
Good. Is it continuous mandatory, or it's continuous spontaneous? We don't have, sorry, it's continuous mandatory or intermittent. We don't have spontaneous and volume control. So it's CMV or IMV.
To me, it looks the same. The shape for the volume, the pressure looks all the same to me.
Not the pressure, because the volume.
The volume looks different.
The volume, like it's volume control, so the volume should not look different. Is that right? And the flow is constant. Is that right?
Yeah.
So to know if it's spontaneous, to know if it's intermittent or not. So you are seeing all of these is triggered by the patient. Is that right? And it's all have the same shape and the same cycle and everything. So here, like there's no that has been done by the patient himself. So it's not intermittent. It's all mandatory breath. Okay? Yes, the shape of the volume maybe when I was drawing is not exactly the same, but the line itself, if you look at the line itself, the volume itself is the same. So this is VCCMVS.
So we all agree this is volume control.
Yes.
Again,
How did you know it's
is it
CMV?
mandatory or CMV or IMV?
Good. So there's no CSV, is that right? We have a deal like volume, there's no CSV. So how can I know, like, could it be intermittent mechanical? Like, yes, it could be, but not in this screen. Because in this screen, what I have right now, if I have someone like I'm standing and watching for more period of time, I can know if like something will change. But from this screen, it's not. Why is that? So first of all of these are triggered, is that right?
Yeah.
But the flow is still the same, square shaped flow, and there's no any changes in the timing itself.
Yeah.
So all of these breaths are mandatory breath. Is that right? If I see this one is mandatory, this one was like, oh, sorry. This one was like changed in the shape of the flow itself. It was decelerating. That's when I say, oh, this is maybe having intermittent. This is the one that has been done by the patient. Or if instead of square, you will see a notch in here. You are knowing that the patient is able to do something while it should be not. Is that right? You cannot do any changes in the like CMV. But if it starts changing, it's not CMV. It's impossible to be CMV. It's IMV, which most of our like more than here is IMV. All right, Hamza. It is like it, but that's why we're here. Is that right? That's why it's 3 years training, not 1 day training. So is it pressure control or volume control? Which is the variable?
So the flow is decelerating,
Okay.
but the volume is still the same.
Good.
I mean, I know it's wrong, but the amount is still the same.
You are right. So the flow is stable. The flow is the same. There's no changes in the flow except it's not square, and the volume is the same. But the shape looks different, and the pressure is all right.
The pressure is the same, so it's like constant
Okay.
shape.
So what do you think then? So let me go back. This is this. This is this. Oh,
Keep that on.
The volume
maybe
is
you
different.
only.
The volume is different. I'll go with PC.
Okay, Hamza. So Hamza said the volume is stable, the flow is constant. And we said, if I can, I will change it from volume control, I will change it to flow control. The line in here is the same.
It's getting the same amount of volume.
The pressure is like changing, yes. Then it's VC. The only difference is like usually like we get tricked with this is like the one that is always in textbook and everything. That's the one like we see with the accelerating in the pressure is the one when you have a square shape. When the patient has decelerating shape, then the pressure wave it looks like very close to the pressure control. See what I'm saying? However, it will not like trick you because you know the flow is constant. Is that right? I'm looking at here. Oh, but it's decelerating. But is the patient doing anything during inspiration? None. Is that right? Is the volume level is the same? Yes. So this is a constant flow. Then it's volume control. So I'm done with what's with the variable. Is it continuous or is it intermittent? It's exactly the first one. There is no
There's no change in the time.
that have VC, C, and VS the same. So both of them are the same, but one with decelerating, one with square. All right?
And when we say lowest constant, we have to take into account both inspiratory and
Mainly inspiratory. Inspiratory, yes. Ramshan, while you're talking. Okay, what's this?
So pressure is constant.
Okay.
Yeah.
Volume is the same. Oh, wait. How is volume is the same? Let me go back. Look at this one. Look at this one. And look at this one. What's the difference in between this one?
The pressure.
The pressure and what else? This
Pressure
one
flow,
and this one.
and the floor is decelerating.
This is decelerating as well.
And it's flow also is constant in this one. But the pressure is also constant. So
So we agree the pressure.
Oh, I mean, what's going on?
Resistance in the flow.
I think it's PC.
It's what?
Resistance in the flow.
So if in here, the one that we saw, it was like this, is that right?
That's right.
The one we saw, but it's very minor changes. Yeah, this patient, maybe he's like paralyzed and the machine does everything for him, maybe. The volume is like for these three breaths are the same. Doesn't have to be changed in the pressure control. Like it's the same mechanic, the same everything, the same pressure. Is that right? So the thing is, like, it's the flow itself. The flow is not the straight, stable flow. There's a little bit of concavity in the top of the flow, and that's what go with a little bit of patient effort. Okay? There's like the patient doing something during this breath. And that's why this is,
PC.
that's a pressure control. And it is,
Yeah.
that's right. How can I,
PC.
did something wrong?
Yeah.
Ah! No, they did.
The toolbox and the wrench at the very bottom.
Which one?
I think it was, yeah.
Okay. Yeah. All right. So this VC, CMV, S. Got it?
So.
Yes. Yes. Go ahead.
So we agree in these waves, the volume is the same, right?
Yes. That's what I would like to give you this. Yes.
So in pressure control, you can still have same, you need to watch.
In 3
more.
breaths or 4. That's
Yeah.
right. You need to watch more, and you need
So
if
you
the
don't need
patient.
to just pick on the volume and decide.
So what you should pick on the flow.
The flow, yeah.
The shape of the flow is better than the shape of the volume. If the volume is obviously up and down,
You're
so
gonna-
yeah, you might know, but wait, if it's like VC, IMV,
Mhm.
the volume could change, is that right? The volume from the patient breath to the mandatory breath, it can change. I don't want you to stick on the basics of like, you know what, yeah, volume the same means that it's volume control. Volume change, that's the pressure control. No, look at all the concept of the flow and the volume. Got it?
Yeah, yeah.
Guys, if it's not, that's why I'm here. If it's not clear, let me know. Clear? All right. Haru, he ran away. This one was for Haru. All right, Mahmoud, it's you, unfortunately. You're the last one.
Control.
What's that?
Pressure control.
Why did you say that?
Because
Okay,
the pressure is the same
that's right.
and the flow is changed.
Good. So, and it is CMV, IMV, or CSV. Who's starting the breath?
It's like the machine.
How did you know it's the machine starting the breath? I don't have any that curve at the beginning. Is that right?
But there is
So okay, good. So it's the like
difference in motion, yeah.
Different everything. Pressure and flow here. The timing.
the time. That's right. So
And I don't know if I can say here that I can
Oh,
say
sorry.
it's IMV or CSV here because
you're right. Because what?
it's hard. Because here maybe I will go with CSV because all are different.
Yes.
But I don't know which.
There's one that has been triggered by the. That's right. You're 100% right. So if, which is my mistake in doing this slide, but if like this one was triggered, so we know it's triggered by the patient, and we don't know if it's cycled by the machine or by the patient, is that right? And then this one was triggered by the patient, and it's obviously it's not the same timing. So who's controlling the cycling is the patient. Is that right? Because it's not exactly the same. But we said if the patient controlling the cycling, but the machine controlling the trigger, it's still mandatory breath. Is that right? But in this scenario, it should be the patient who's the one who's controlling the initiation and the cycling. Then what we call it? CSV.
But there is no patient trigger.
Exactly.
That's right. That's what I said. My mistake. I did not. I can't do mistake, guys. Come on. All right. So that's VCCSV. Is that right? Got it. All right. And we discussed about that as well. Volume control when we have a square shape. Is that right? And we said if there is problem with the resistance, I don't have to do calculations. By just looking at the wave, what's the pressure required to push the air at the beginning? That's the peak pressure, is that right? Mm-hmm. If I require a lot of peak pressure to push the air at the beginning, it still could be resistance or compliance, is that right? Resistance or compliance. But if that pressure is high, but the other pressure, which is the plateau pressure, is normal, that's resistance. If both are high, that's compliance. How can I know that with just looking? In here, we said the green one, which is the resistive, if it's going up, like, and the end of it goes up as well, which is the green one in here, that goes with resistance. Look at the blue one. That's how the compliance will show up. So at the beginning, it will be like small, and then it will be like very high because that's like a compliance problem more than pressure, like problem with the end of it.
And the green one can be both.
Yes, it can be. Yes, and then you have to do like your the difference between but Hamza, if you mind, can you like if volume control with decelerating, we said it will be not the same. Look how the resistance will show up. Oh wait, why the pressures looks so different? And I had that when I was a fellow. I was like, this is weird. This looks the opposite of a regular pressure, because the regular pressure will be like starting low and then at the peak. Is that right? It's the opposite of it. The green one. Yes, the green one. If you see the green one,
time become low.
that's right. That's the problem with resistance. There's an obstruction. If it's the same in here, it starts low and then like it ends high. That goes with compliance. Can I know like every one that you will show me, I will be 100% like right? No, you like, but it give you a clue to make like you will look at the flow, you will look at the inspiratory and expiratory to know more. Okay. Yes.
If there's a small air obstruction versus large air obstruction,
it will
can give you different.
It can like the way, because it depends. Like if it's large airway obstruction, usually you will see like from the beginning early resistance. If it's small airway obstruction, will be like in the late resistance. However, like the pressure, it's a continuous pressure. It's not just like one pressure goes in and that's it done. It's a continuous pressure that will show you. But can I make sure and like just differentiate by looking at the wave? Me personally, no, and I don't think it's doable. But I don't know. Do you know? Just me. All right. And this is expiration. So expiration, if the patient, the black one, which is the normal breathing, if the blue one, which is the lung goes back to normal quickly, that's like high elasticity, low compliance, that's right. The red one, the patient trying to do something. So there's a PMOS, is that right? That's what we talked about. All right. Now let's talk about our topic from today, which is not a long topic. So volume. Is the FRC, which is the functional residual capacity, is it the same in this patient and this patient, this patient, this patient? The FRC. Like functional residual capacity. It's not, is that right? Can you calculate it by just looking at the CAT scan? Nowadays, there is a machine can do that for you, but with just looking at the CAT scan, you cannot know the FRC, is that right? So the thing is, if I'm giving volume, all of us, if I ask you, wow, what's the RDS, like how much should you get? 4 to 6 ml per kg ideal body weight, is that right? So why we have this thought? Why we thought like we should go down from 12 to 6 or 12 to 4? So it's the conception of like baby lung. So the normal lung in this patient is less than in this patient less than in this patient, less than in this patient. Is that right? So the volume, it depends a lot of like what's the disease that you have, how bad is your lung is, which mainly the functional residual capacity of your lung. Unfortunately, no one of us can know what's the FRC, because if I know the FRC, it will be very easy to decide how much volume this patient will receive without any complications. And how can we do that? So we have barotrauma and trauma, okay? The barotrauma, which is the pressure injury, and that's what we call the stress injury. And the volutrauma is the strain injury or the volume injury. Is that right? Oh, let's just think about it. The barotrauma is something and the volutrauma is something, or they are related. What do you think? Related. So both of them, it's continuous. Like it's like we talked about the equation of motion. It's like the resistance and the flow with the volume and the elasticity. Is that right? All right. So when we think about pressure and stress, what's pressure and stress? So I need pressure to overcome the resistance and push the volume to all the alveoli. Is that right? What's the name of that pressure? The peak pressure. That's dynamic. Is that right? The peak pressure is the positive inspiratory pressure. The more accurate name. The positive inspiratory pressure is the pressure to push the volume inside the airways. Is that right? And the alveoli. If I block the airways and I stop breathing, the pressure is still inside the alveoli to keep the alveoli open. What's that pressure? P. So, okay. I push the air with the pressure. That's the positive inspiratory pressure. And then I stop. Kareem said this is the plateau. I'm still during inspiration. I did not exhale. Okay? That's the plateau pressure. Pressure inside the alveoli right now is the plateau pressure. And the pressure around the alveoli, which is the pleural pressure, does that affect my how much the alveoli will expand it, how much the alveoli will be like atelectatic? Yes, is that right? That's why we have the esophageal balloon to estimate what's the pleural pressure. What's the transpulmonary pressure? What is transpulmonary pressure?
-1.
Not what's the normal. What's the normal range? Like how can you calculate transpulmonary pressure? There's transthoracic and there's transpulmonary
The alveolar pressure, which is the
alveolar pressure.
Yeah.
Okay.
And then the pleural.
Good. The alveolar pressure and the pleural pressure. So if it's during inspiration, it's the plateau pressure minus the pleural pressure. If it's during expiration, P minus the pleural pressure. But unfortunately, we don't know the pleural pressure. Is that right? We're just like estimating according to the peak and the plateau pressure. So this is the stress. So always we sit, oh, if the peak is more than 35 or the plateau is more than 30, this patient has a high risk of barotrauma. Is that right? Which is stress injury. Because of, is the pressure inside the alveoli much higher than the pleural pressure and the alveoli will rupture? Or the opposite, is the pressure around the alveoli, it's higher, and that will lead to atelectasis and problems. Is that right? And we don't know without having, we don't know 100% without having like measuring the pleural pressure adequately. What's about strain? What's then about the strain? Strain depends on the tidal volume. So we said tidal volume, and I mentioned functional residual capacity. Is that right? So the how to have I'll say. So if I would like to give you enough volume, that should be calculated according to how much lung you have. Is that right? I cannot just like decide now. All of you started from Dr. Becker like going there. Okay, I will start 500 cc in all of you. Let's say Mahmoud, he has only one lung.
250.
That's right. So I don't know. Is that right? Kareem, he has like bilateral infiltrate. Hamza, he has an ARDS. But I will give you all 500. Despite that, all of you, your FRC is not the normal. It's not the same. Sorry. All of you, FRC is not the same. Is that right? How can I do that? Let's say that I have a 45-year-old patient with FRC of 1,000. Okay? And I have another one with FRC of 100. And I decided to give them both 500 of volume. Is the strain the same?
No.
It's not. What's the strain? Is the tidal volume divided by
the FRC. So the strain for the first one is 0.4. The strain for the second one is 4.25. But how can we put these together, the stress and the strain, and please, Dr. Megri, just like, I would like to apply this on a patient. Yes, that might help me for my board, but I need to know how that helped me for my real life. Is that right? Mm-hmm. All right. So stress equal constant times strain. Do I need to memorize that? No. I need you to memorize the concept to understand both are related. Okay. What's the stress, Mahmoud, we said? Stress injury, how can I calculate during inspiration? What's the stress?
Alveolar pressure minus pleural pressure.
So during inspiration, alveolar pressure is? Plateau or peak? Plateau, is that right? Plateau pressure minus alveolar pressure. So, and so that's why we say airway pressure minus pleural pressure. Airway pressure is the plateau pressure during inspiration, P pressure during expiration. Unfortunately, we don't know the pleural pressure, is that right? All right. What's about the strain? It is the tidal volume divided by the FRC. Know the tidal volume because they are the one who controlling the tidal volume, but unfortunately we don't know the FRC, which that's where we go like the baby lung, how much the size of the lung left. Okay, so the relation is the constant, the K in here, is the elasticity. How is the elasticity related to compliance?
Increase elasticity, low compliance.
That's right. So elasticity equal 1 divided by compliance. Is that right? It's the reverse of the compliance. Is that right? All right. So what they found is when they did other people, smart people, not me. What they did is they did when they looked at the relation between the stress and strain. They said the constant is about 12 centimeter water. So if I have a constant pressure on this side, and I want the constant to stay 12. So I have plateau minus pressure equal 12. How can I make this happen? Plateau minus pressure equal 12. Despite that I have tidal volume and FRC in the other side, is that right? So how can I make the plateau minus alveoli equal to 12? And I know the constant is 12. Let's make the question more clear. So stress equal constant times strain, is that right? If constant equal 12, how can I make the the stress equal to 12?
So strain is 1.
Strain is 1. How can I do strain is 1?
The tidal volume over function as it. So if your FRC is high, you need to go up on tidal volume.
So you need to give me a tidal to equalize, is that right? I need a tidal volume to FRC to be like 1. Mm-hmm. That will give me a normal stress, which is 12. Mm-hmm. If my tidal volume, let's say it's like that divided the tidal I gave to Mindy, her FRC is only 100, okay? And I gave her 500 cc. Her strain was what? 4.5, is it? Or 5?
5.
Yes. The 5 times 12, that's what's our strain, which is
60.
That's very high, is that right? I mean, that's what's our stress, which is very high. So what controls this side of the equation actually is this side of the equation.
Because we're able to control this one, but this one is not.
That's right. So that's why we say in the bid side, let's give 4 to 6 ml because they thought it should be okay because if your lung is very, very bad, it shouldn't be a QFRC like less than this. However, it's not the end of it. So in here, increasing in tidal volume of the lung relative to the FRC by the factor of 1 will result in transpulmonary pressure of 12. That's easy. That's what we said. Is that right? Mm-hmm. That's what Hamza said. If it's 1, are you sure, guys? It's Kareem. No, that's okay. That's okay. So stress equal constant times strain. Is that right? Mm-hmm. Stress equal constant times strain. The normal constant, the elasticity should be from 12 to 25. Okay. Let's say that I need to have a stress of 12. Stress of 12. How can I make that? The other side of the equation, which is it's constant times something, is that right? So stress equal 12 means I need to make the tidal volume and FRC equal 1. Mm-hmm. How can I do that? I will try to put the tidal volume equal to the FRC to give me 1. Then the stress will equal constant. Is that right? Mm-hmm. Got it? So if my strain increase, which is the tidal volume, if my FRC goes down or tidal volume goes up, then the stress and the risk of barotrauma will go up. Is that right? So the total lung capacity, when we do a lung volume, lung function test, we ask us like to breathe normally, take a deep breath in, and then out. Is that right? That's for the spiral. But for the total lung capacity, when we do like the plethysmography, we ask the patient to just try to breathe, and then we count the volume inside the room and like what left. I mean inside the box.
The chamber.
That's right. And then we can calculate what's the total lung capacity. They found when you are on your total lung capacity, the strain is around 2.5. Okay, so the difference between your volume and the FRC, the ratio between means that your constant, the transpulmonary pressure will be equal 30.
Sure.
Is that right? That's the highest. But they said like patient in the ICU, they will not make them go to the maximum strain and elasticity. They did another study, found that like to have all the lung units, not all, you cannot do that, but like at least most of the lung unit, like strain and stress to be away from having barotrauma or volutrauma, you want it to be around 21. That's why when you read, if you open any topic right now and you read about like the balloon, the esophageal balloon, what do you want? What's the number for esophageal balloon? Like you need your pressure during inspiration and expiration. What's the number that you look for? Yeah, what do you look for? So during expiration, you're looking for like should be 0 to 10. That's the highest. During inspiration, not more than 25. Is that right? Do you know these number, guys? That's okay. So the esophageal balloon, when we measure, what we do with the esophageal balloon? To know the pleural pressure and to be able to measure the transpulmonary pressure. And we try, this is a obese man, his peak pressure is 35, I think he can take more. Is that right? I put the esophageal balloon and I measure the pleural pressure. I find that during expiration, his pleural pressure is higher than the alveolar pressure. So I know that there's like compression from outside, is that right? Then I can keep increasing the PEEP without even thinking about the peak pressure, is that right? I'll increase the PEEP to keep it during expiration, to keep the alveoli open. The same during inspiration. I found that the alveolar pressure is much higher than the pleural pressure, which is like a high risk of rupture. That word, much higher, what's the number we look for? We don't want it to be more than 20, the difference. Is that right? From where did they get these numbers, which is this relation between the stress and the strain? Okay, for the first time, maybe it will not get like click in your mind that quick, but try to repeat again and again. Okay.
But how will we determine our patient's FRC in order?
Like if I know that, I'll stop medicine and I'll be like a millionaire.
Because they cannot make it run without.
So that's why we cannot. But as a physician, I will come to the mechanical ventilation. I will start 4 ml per kg. Let's say he's an ARDS patient. He has a very small baby lung size. Okay, and then I put him in 4 ml per kg. His peak pressure is 50. His plateau pressure is 45. He's a normal pill patient. So we know that we should not be that high. Is that right? So that's from where did we brought these numbers, the 35 and 30 from this relation. Okay. So now if I say like if it stays around 30, I know his stress and strain in a good side. But I need to know more. Then put a esophageal balloon. Is that right? If I put this esophageal balloon and I find out that his inspiratory pressure, the plateau minus the pleural, is 40. So how can I change it? I can decrease the volume. Is that right? I go down to the volume until that difference will become like 20. So what I did, I'm trying to decrease the volume to be close to the FRC, which I don't know, but it's estimate from the other side of the equation. There's a machine with a magnetic, like it's a CT scan, like not CT scan. You put like leads in the lung, give you like a magnetic field. It calculates how much of the lung is affected by the consolidation and how much of the lung is not affected by the consolidation. And it will give you the FRC, and then you can titrate your PEEP and volume according to it. But there's no big studies like to say, yes, we should all start doing this. Got it? Any questions? Even if you know this, you cannot be equal for the lung. You cannot. Like, you will be a little bit not equal. Why is that? Because if it's a normal lung with a normal airway, if I give a volume of 500, that 500 might go like equal distribution, is that right? But I have some alveoli is not working well, some airways is not working well. We know that we are not giving everything equally to the lung, is that right? Maybe it is, maybe it's not, but most probably it's not. There's something called the stress tracer. I want you to know that as a pulmonologist, you need to know this term. What's the stress tracer? So if you have one alveoli or one part of the lung, not alveoli, is affected and like it's very consolidated, and you're trying to give more, you're trying to give volume, and that will open the rest of the lung, is that right? That area of consolidation, it's the stress tracer. What does that mean? It's holding the other part of the lung. So your inflation of the normal part of the lung can lead to barotrauma. So even if you do everything in the right way, and next day I come and Karim say, hey, Dr. Megri, by the way, the patient that you stood by the mechanical ventilation for 1 hour, and you pretend that you know and like explain to me everything about it, ended up with pneumothorax. Is that right? Like, oh my God. Okay. Then what I'm doing, it was not giving like to a one part of the lung. Got it? That's what we call the stress tracer. You don't have to go in depth in it. All right. Mahmoud, because you answered this one. Is it pressure control or volume control?
Pressure control, CMVS.
So why did you say pressure control?
Because the pressure waves are the same and there is difference in the flow.
So the flow is not stable, is that right?
Yes.
The flow is not the same in each one, is that right?
Yeah, there is a PMAS.
Before BMOS, so that's a volume, that's a pressure control.
Yes.
Is it continuous or spontaneous? Is it mandatory or spontaneous? Sorry.
It's mandatory.
Why did you say mandatory?
Because started by the machine and cycled basically.
So this one cycled by machine.
The first one.
This one?
Yes.
Okay, cycled by the machine,
Yes.
and then had another breath,
Yes. That's the
cycled by the machine, and then he had another breath. Unfortunately, I cannot differentiate because it was like stuck to it.
Yeah.
And then he had this one and this one. Is that right?
Yeah.
So the question is like, is this continuous mandatory or it's IMV? So what does that mean?
It's different in shape.
So it could
So he said,
be IMV.
Was that?
so the first one, you said by machine, second one by machine, but it's different in shape.
That's different. In the whole shape is different. Is that right?
I
What
think
does that mean?
I think it's IMV because in the first one he's trying to
By the patient itself.
Okay.
Second by
he's
the
trying
machine.
Trying
breathe,
to
yeah,
try what?
try to breathe before.
Good. So
the
in this
finish.
one,
It's not
No
straight.
machine.
so in this one, let me try.
Is it the machine started
Yeah,
in the
that's-
patient?
That's early cycle, yeah. Early.
So this one, oh.
That's the only difference between the two. You know?
But the other two look similar.
That's early trigger by the patient basically.
So this one, it should be like this, is that right?
Yeah.
Straight line,
Mhm.
and like this. And then I have another breath, like this. And then like this. Is that right?
Right.
But in here, I have a little bit of notch in here, and then I have a whole breath extra in here, is that right?
Yeah.
So what happened? So this patient, he tried to take a breath in here, as Hamza said, he's trying to breathe. So what happened is his muscle activity started at the end of the machine breath.
Mhm.
But this is a pressure control, so the flow is not constant. He can't change the flow. So when that happened, his pressure was high enough that it triggered
To give him.
another breath. Is that right? And that's the other breath that was triggered. And during expiration, look at this. So we said during expiration it should be like this. Is that right?
Mhm.
All of that extra is what? During expiration. So we said it should be in one line.
It's PMOS.
That's
because
PMOS.
it's-
So he has a lot of muscle activity during inspiration
And expiration.
and expiration. And in here, it happened again. So he was breathing. It will go down. It should go down like this and down like this.
He tried to breathe and go
But
up
he breathed and he triggered another breath.
because of the pressure.
Why do I know this should be like this? This one, it should be like this. Because if I look at this one, which is this one, doesn't have like a lot of PMAS.
Normal.
That's like the one that is driven
Close to-
mainly by the machine without the patient doing a lot of effect.
So the first one, the patient initiated, is that right?
Yes,
And
the
then
machine
The
initiated.
machine initiated.
And
But
then
the patient
There's
At
daily
the
trigger.
end, the patient tried to trigger.
decide to breathe.
Okay.
that's right, you're
Because
right.
the volume is not enough.
So I asked Katabi to do what? To go down on the rate
Yes.
to let the patient
Breathe.
breathe by himself and see what he gonna do by himself.
Mhm.
He told me to do something, is that right?
Yeah, accept. Or just click on that toolbar, yeah. You have to.
Call for help.
Oh, he's
Yeah.
All right. Here, he reduced the rate to 12. So all of the breaths was by the patient. We did not see that breath was started by the machine.
Mhm.
Okay, in this one was 24 or something, their respiratory rate in this one. So the machine will time breath and patient decide he needs a breath right now, but it will be supported by the machine. We decrease the rate, that's what happened. However, it should be looking.
Yes, there is a.
I'm still expecting the flow will be.
All right, so it still be
On this.
like this. No, not like this.
Yeah, be muscle expiration, so.
Should be like this, is that right?
Mhm.
But the patient still having activity. The patient still like trying to need more volume or more pressure to do it, is that right?
Mhm.
But the rate, like he does not have that much desynchrony. We changed this without giving him more sedation, is that right? Then I asked him again. I asked him to switch him to CSV instead of CMV, pressure support, and let the patient control his time. That what happened. You see, so he's like the flow, and he still have PMAS, he's doing everything, but the patient he's getting a good volume. The patient but he's still using his muscles during inspiration and expiration. That's the time when the physician should intervene. How does that mean? What does that mean? Is this patient in severe septic shock, sepsis, and the movement of the muscle is out of control, and it's just secondary to patients feeling tired and trying to breathe more and more? Or he is trying to have more volume, or the patient himself, like what the settings that you are on right now, it's not the right setting for him. So that's why we decreased the rate first, and we looked at the patient, what he gonna do? He was not desynchronous anymore, but he still have some PMAS. We put him in pressure support. The patient, he was doing a good volume, 378, and he was doing good. There's no any problem with the patient, is that right? Then you ask yourself a question, as Dr. Jasmine said in that lecture when we had the board review, when some of you asked like, oh, you can put patient on pressure support while they are in sedation? And he said, yes, if the patient can breathe, and he's doing fine, and like the volume is stable, that's it. You don't sedate him more. So that's why it's very important to know what's the machine is doing, how can you fix it. Oh, you think like from different? No, actually, like me, like personally, during my fellowship, it was like rocket science for me. Like I was like, what they are talking about. And then with time, like okay, every patient who's in mechanical ventilation, while I'm under ICU rotation, I will look at it more and more and more, and like okay, let me buy a mechanical ventilation book. Let me look more. Why I'm doing that? Because you're an intensivist, is that right? You have to know. You have to know, and you will learn more during fellowship and after fellowship, and that's it.
And still the set point because patient initiates and patient ends, or is it another?
The set point is not for who's ending or like who's controlling the machine. So the set point means that I'm the one who asked the machine to end the respiratory breath in this time. I give her like a specific volume and time. But if I said, hey, machine, you can stop whenever you want by looking at this. So the machine will do, okay, I will stop if the volume reach 500. I will stop, not the volume measure. I will stop if the patient 3 sequence of breath, he has this time of minute ventilation. That's not set point. I'm not the one who said that. That's the machine taking control of that. So that's like something like that's when you say adaptive. But like dual, when I'm doing some and the machine doing some.
So the first one that we saw when the patient was also adding breaths was the one with our dual scheme. This one. Is
This
a dual
one.
scheme?
So this one, if you look, the distance, it wasn't like in here because it's like a pressure control. Is that right?
Mhm.
So the like you are controlling the pressure, you're not controlling the flow. If you see all of his pressure timing, it's the same. So it's set point. However, he was able to trigger the vent. So if I get to change something in this patient, I will say like why the machine is having early trigger. The machine is trigger before the patient start the breath.
Yeah.
Whenever the machine trigger, then the patient decide to have a PMUS. So there's 2 options. Easy physician, take off the PMUS and paralyze the patient. You will see like a beautiful picture, but a bad patient. But if you would like to stop by, okay, why he is using his muscle? Is he using his muscle because of this or because of that or because of this? How can I oh, he's not ready to be extubated. And he's using his muscle a lot, and this patient, he will fail if I leave him like this. So that's why I need to paralyze him and blah, 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 blah. So there's like, that's why you have to think. And then
this one, this is the pressure control. Can you go back to the first one? So
This
if I
pressure
want to
control.
see PC,
Yeah.
if I want to look for like who ended the cycle here, I just gonna look for the first one, right? The pressure, right? I'm not gonna look for the flow, right?
That's right, because it's like you should look at the time for the pressure and the flow. Okay, like but the flow is not constant if there is a PMUS. If there is no muscle activity by the patient, then you can look at the pressure or the flow.
Okay.
But because there is muscle activity, that can change in the flow itself.
But
the pressure will not change.
It's important to know what kind of desynchrony, like this is like cycle.
Yes,
early.
and we'll go
to
over
know-
this. So
know how
from
to
now
do
go
that.
on, what we'll try to do is we'll try to have like if I have some, but if you can help me guys, if you have anyone with desynchrony, just take a picture of it, and we can like have a discussion about it. Like we'll try to bring like early and late cycle, early and late trigger, like PMUS, high elasticity, and double triggering, and failed trigger. Those are the.
So what we call
This
this
is-
one?
this is double
So this is double triggering because of PMUS.
Yeah, okay.
So how will the work shifting look like?
Double triggering.
Good.
Is there a difference between double triggering and early cycle? Like,
No, the thing is like when you say double triggering, always as a good physician, why there is a double? Is it because of early cycle? Is it because of something else?
false.
Yeah.
So do you call this double triggering or breed stacking?
Yeah, I don't like to use breath stacking, but that's like that's the machine. Like the machine triggered the first one, the patient triggered the second one. Is that right?
Mhm.
But some people, they will say this is the reverse triggering. Is that right? Because the machine triggered and then I triggered. So if I would like to know if it's reverse trigger or not, that's why I asked Katabi to do what?
Decrease the rate.
Decrease the rate, and let's look. If it stays the same, then that's reverse trigger. The patient needs to less sedation, not more sedation. If it's like it did not stay the same, it's just the timing of when the machine is giving and the patient is giving. And that's why nowadays we don't call it reverse triggering, just early triggering.
And by decreasing the rate, basically give more time, so you can give more time for to exhale.
And look at the patient
Then-
mechanics and see how he does. For your question, Ramsha, PMUS, which like work shifting, is the red one. You see a red one in here? So if you are pulling down during the pressure in volume control, that's when you have like a PMUS. In pressure control, so you see the PMUS where we see it mainly in the flow. Do you see this one? In the flow, okay? So if I go back to this one, oh, what is it? If I go to this one, do you see how it's not? How it's not just a regular line like this, because all of this is PMOS. That's the work shifting. But work shifting can be like very, very, very high. That will change the whole settings of the mechanical ventilation, or it could be like mild because the patient is trying to breathe.
How is the resistance gonna show you, like prolonged or?
What do you mean?
Can I say this resistant?
You cannot say because there is a PMOS. But why? It's very, very, very tricky. It's very, very smart question, Mahmoud. But the thing is, the problem is, this is the curve, how it looked like. Is that right?
Yeah.
If I have resistance, maybe it will be like this, and it's not back to normal. Is that right?
Yeah.
How can I know this is because of resistance or because of the PMOS? If I see PMOS at the beginning and PMOS in here, and I know my patient, so most probably I will say this is PMOS, not resistance. You cannot differentiate between, if this was normal, like this, straight and cut down, and then like this and straight and like this, and this is the line. So I know the inspirator did not go back to the baseline without any activity, and did not go to the baseline without any activity. So this is resistance. Got it?
So I still struggle with the flow. Like when I sit the ventilator, especially at St. Mary. So how could I decide on the flow, like 25 liter, 30, 60, you know?
So when you change the flow, it will change. So what's our normal flow? Like roughly? 6. Like some says for like 40 to 60, some says like 60, some says higher than that. Okay, but like if my patient has COPD and I would like to decrease the inspiratory time, what would I do? I'd increase expiratory time.
Increase the flow?
So increase the flow,
Yes.
that will decrease
Time.
the inspiratory time.
Yes.
If I decrease the flow,
Will increase
Will
the
increase the inspiratory.
how do I know if this patient, if this is sufficient flow for this patient?
That's what
Yeah,
my question is.
Was that? Okay.
How could I know this flow is appropriate?
So what I will
be?
be, do you know that from the back they said flow starvation? What does that mean, flow starvation? It's the same work shifting. There's just the change names from flow starvation because it's not always flow starvation. If my patient's starving for flow,
That's what
he will try to do more.
Mhm.
He will see the PMOS during inspiration and expiration. So if the flow is normal, but if I increase the flow to 60 and the patient's still doing it, I know it's not flow starvation, there's something else going on.
Something else.
But if like everything is stable, everything is like perfect, and then the patient still have the PMOS trying to pull more, and my flow was 30, I went to 50, and it's disappeared. I know this patient was just asking for higher flow. He's higher, like he needs higher flow to be delivered fast. Got it?
Yeah.
All right.
Smart question, Dr. Bozil.
But always make sure that you clinically correlate these findings to your patient. Sometimes patient may, breathe quickly and their ventilation is 12, 13, 14, and that's because he's floorally septic or has infected. It's more physiological than
This is the most important thing, guys.
sometimes like you have to treat the cause, like septic, they're breathing too fast because he has he's
Physiologically compensation for, yeah.
So sometimes you have to always clinicate the numbers, always. Thank you, Mohammed. That was great.
Thank you.
Yeah, thank you so much, Dr.
Thank you, it was
Very
good.
Love you.
شو قلنا واحدة لاعب
أعتقد فيه